Yeah, just before we start, when I made the ruling permitting Mr. Cooper to call Mr. Andy Della Pizzi, there were certain restrictions, and I'm just reading from the request of Mr. Cooper. And this is what I said. I said the first witness he wishes to call is Dr. Della Pizzi, the Deputy Chief Health Officer for the Northwest Territories, to give important information on the creation, explanation, and promulgation of COVID rules. In this case, Mr. Cooper's request is reasonable, and I'm going to allow him to testify, and therefore a subpoena will issue, returnable at the conclusion of Mr. Norn's testimony. Mr. Pizzi, welcome to the inquiry, and we appreciate your assistance. And
I would ask that Mr. Della Pizzi be sworn or affirmed.
Would you like to swear or affirm?
Swear?
Do you have a Bible there?
No, I'm sorry, I don't, so I apologize.
So you'll affirm?
Yes.
Do you affirm that the evidence that you shall provide today will be the truth, the whole truth, and nothing but the truth, so help you God? Oh, I'm sorry.
Yes.
Nothing but the truth. Sorry. Thank you.
Just before we turn you over for cross-examination, I'd like to begin by informing you that pursuant to Section 8 of the Public Inquiries Act, you do have the right to object to answer any question under Section 5 of the Canada Evidence Act. The Public Inquiries Act also provides that any witness at an inquiry shall be deemed to have objected to answer any question asked of the witness on the ground that the answer of the witness may tend to incriminate or may tend to establish the liability of the witness to a civil proceeding at the instance of the Crown or any person, and no answer given by a witness at an inquiry shall be used or be admissible in evidence against the witness in any trial or other proceedings against the witness taking place after the inquiry, other than a prosecution for perjury in the giving of evidence. Do you understand that, Dr. Della Pizzi?
Yes.
Okay. Then I turn you over for cross-examination of Mr. Halaba.
Mr. Halaba, I understand you'll be cross-examining the witness. You go ahead, sir.
That's correct. Thank you, Mr. Barclay. So is it Dr. Della Pizzi or Dr. Pizzi?
It's Dr. Della Pizzi.
Dr. Della Pizzi. I may refer to you as Doctor, just to shorten that. So, Doctor, how long have you been the Deputy Chief Health Officer for the Northwest Territories?
Since 2019.
So 2019. And before that appointment, you were practicing in the public?
I was a family physician from 1999 until 2015, and then I pursued a public health residency at the University of Calgary and started working in Northern Territories in 2018 and then in Northwest Territories in 2019.
Okay, so nearly a 16-year stint as a family doctor. In which province, or was it in the territory?
It was in Manitoba.
It was in Manitoba? All right. And what, even though so you were a general physician, but did you specialize in any one area?
I had a family practice in Winnipeg at a community health center. I also worked as a hospital and inpatient hospital physician. I used to work in rural and remote areas, providing coverage for rural and remote communities. I worked with the tuberculosis program in Manitoba for a number of years, and also with the University of Manitoba. For almost 10 years, I helped out with the Department of Continuing Professional Development. And then I pursued a master's degree in public health and my public health and preventive medicine residency the residency started in 2015.
Okay. So in terms of communicable diseases, tuberculosis was something that you, one of the diseases that you focused on. Was there any other specialization in studying communicable diseases?
Our public health residency program specializes as a specialist in public health and preventive medicine. A major component of that training is communicable disease control. I also pursued a master's MSc in public health, and took a number of additional courses, specifically in communicable disease control, for the purpose of my master's.
I'm sorry, doctor, you're breaking up there. I didn't get that last sentence. Oh, you're frozen.
That for the purpose of my my MSc, my master's degree. I wonder if I should turn my video off. I worry about our bandwidth a little bit here.
No,
You just take your time and
it's probably best to keep your video on just to ensure
Okay.
that. So as the Deputy Health Minister, what are your current responsibilities in terms of the COVID-19 pandemic in the Northwest Territories?
So as the Deputy Chief Public Health Officer, I have different duties. One main duty is to support Dr. Candola as the Chief Public Health Officer. Helping Dr. Candola for consultations. We have our office works together collaboratively. We have a large part in the surveillance, so the gathering of information and the analysis and interpretation of that information, and then disseminating that to the field and healthcare providers. So surveillance is a major component. Also, we're playing a lot of stewardship roles, so planning and implementing programs or planning a response to the pandemic. For specifically, for communicable disease control, we have our Public Health Act in Northwest Territories and our reportable disease regulations, and in those regulations we have a communicable disease control manual. So our office updates that manual, which is specific guidance for healthcare workers on management of COVID-19. So this is similar to other provinces. We all work together in terms of other activities, especially things like communicating to the public, working with many stakeholders in the Northwest Territories, whether it's schools or business or other professions. So really it is in the Northwest Territories, it's a wide scope of work for public health physicians.
Do you speak directly with policymakers regarding COVID-19 measures or give recommendations?
So when in terms of legislation, Dr. Candola, Chief Public Health Officer, is responsible and accountable for producing that legislation, and Dr. Candola consults people as she sees fit, and she has advisors in our office who help her draft the public health orders and the legislation, and I'm actually minimally involved in that process. I will be consulted on some occasions, especially to ensure.
Sorry, you broke up again. The last thing I heard was to ensure. Sorry, doctor.
Am I breaking up? Can everyone hear me okay?
Yeah, the last thing I heard was
hear
to
your
ensure.
last couple of minutes of testimony. Perhaps you could rephrase and ask the question again and give the doctor a chance to respond.
Sure, doctor. Again, my question was regarding policymakers. If you have, if your input affects, sorry, the way you described it, what I received from your response was that Dr. Candola, the person who would be making these policy recommendations or decisions, and how are you involved in that?
So Dr. Candola, as the Chief Public Health Officer, is responsible and accountable for creating the public health orders under our Public Health Act in terms of the COVID-specific public health orders. And she consults with people in our office as necessary. So she has advisors in our office, or will consult with our Chief Environmental Health Officer, for instance, and some matters, but it's quite, I've had minimal involvement in creating the...
Sorry to interrupt. This is Jenna, the court reporter. You're really cutting in and out, and your video is not aligned with your voice. I don't know if anyone else is noticing that.
Yeah, no, it's noticeable. Do you have any issue with the camera going on?
I do. If he shuts his video off.
It's,
Yeah, then
Well, try turning the video off.
I worry about our bandwidth here. I could come down to the Legislative Assembly if that's most appropriate, but I could try like this, whatever is recommended.
Well, let's just try it without the video to see how it works.
Okay.
And so, again,
So what was the last thing that you heard?
that you were minimally involved? After that, I didn't hear. So,
Yeah, so I'm minimally involved in drafting of the public health orders. Dr. Candola will consult myself or our communicable disease control team on some issues, for instance, making sure that some of the policies are in the order aligned with our communicable disease control guidance. So I'm very minimally involved in drafting of the public health orders for COVID-19.
sure. Now, that communicable disease control team, who is that made up of?
Could I just interject here? This is Karen Taylor, counsel for G&W.T. I'm just wondering if any of this is really relevant to the matters before the adjudicator here today. I mean, Dr. Delapizzi's given a fair bit of background about who he is and what his role is. I'm just not sure we need to go further with this setup.
Well, counsel, there was some of the issues were potential breaches of the self-isolation plan. These all come from policies, which is why I'm trying to get to the heart of how these policies came into play.
Yeah, I think that's a fair question. I think that's a fair question. You go ahead.
Thank you, Mr. Barclay. Sorry, Doctor, who makes up the communicable disease control team? Are these specialists in studying these diseases, or do they have some sort of enhanced knowledge?
Yeah, so they are specialists they are communicable disease control specialists who have experience and skills in management of communicable disease. And so they make up the team. We have a number of communicable disease control consultants, and myself and Dr. Candola plays a big part in that team as well. So it's a group that works together.
Sorry, did you cut out there, or were you done talking?
My last words were, it's a group that works together.
Okay, perfect. Sorry, just went really silent there.
Yeah, he's coming through very clearly now.
Oh, wonderful. Okay. So down to basically COVID-19 itself. To the best of your knowledge, how is COVID? I mean, this has changed over time since the beginning of the pandemic. But to your understanding, how is COVID-19 transmitted?
So COVID-19, is transmitted through respiratory droplets and also through airborne transmission. To the best of everyone's assessment, the World Health Organization, for example, produced a scientific briefing on the transmission of COVID-19, where their estimate was that the majority of infections are still transmitted by respiratory droplets, and some infections in certain situations could be transmitted through airborne means. Respiratory droplets mean that, as a person is talking, singing, sneezing, that there are particles coming from their respiratory passages, and those tend to be heavier particles that fall to the ground within about a 2-meter radius of that person. So direct contact with those droplets within 2 meters is considered to be the most prominent way that COVID passes from one person to another. But there are also smaller particles that can remain suspended in the air and travel across larger distances, like across a room. And there is increasing concern that COVID-19 can be transmitted in specific situations, perhaps when an individual has a high viral load, or when the environment is such that there's poor ventilation or a constraint, a smaller space, that it can be transmitted through airborne means as well. The other, we also we're concerned at the beginning of the pandemic about indirect transmission, meaning that it can be transmitted from surfaces. So if a person coughs or sneezes and there's virus on an inanimate object, like that another person might touch that and develop COVID that way. And that is still possible, but it's likely a very low proportion of infections that are transmitted that way. The US CDC, for instance, estimates that, if there was virus on a surface, many thousands of people might have to touch that surface before one person developed an infection. and maybe they would have to touch their eyes or nose in that means. So indirect transmission through surfaces is thought to be much less significant than respiratory droplets or airborne transmission.
So what you're saying is, I mean, at the beginning, I do recall, sanitize your hands, wipe surfaces, certain disinfectants were sold out for that purpose. But what you're explaining now is that someone, the virus being present, let's say on a office phone or a table, if someone else goes and touches one of those surfaces, they're going to have to then touch their eyes, and it's still such a minuscule chance that you need, it's 1 in 1,000.
Well, the US CDC estimated that if there was virus on a surface, that many thousands of people would have to touch that surface before one became infected. So that's their best estimation. So the risk of transmission through indirect means, through inanimate objects like that, is low but not zero. And we certainly still encourage disinfecting and appropriately disinfecting surfaces. It's just that most infections are attributable to transmission through respiratory droplets or airborne transmission.
Doctor, would you say that's over 95, 98% are attributable to airborne transmission or droplets?
I think it's hard. I think, we actually looked at the epidemiology, and it's hard to find studies that actually document the attributable portion, but we believe that the infections are transmitted mostly through respiratory droplets or sometimes airborne transmission.
Okay. Now, how does infection change, or how does transmission change if someone is exhibiting no symptoms, but yet they're COVID positive, let's say?
I'm sorry, could you repeat the question?
Sure. Let's say there's two people that are both infected with COVID. One person is exhibiting quite a few symptoms, whereas one person is symptom-free. Is there a difference in how these two people could transmit the virus?
It's certainly possible. We know that transmission can occur.
Sorry, I lost you after transmission can.
Sorry, transmission can occur from a person who's not having any symptoms. We learned this early on in the pandemic, that asymptomatic transmission can occur. Sometimes when we also know that when people are having a more severe illness, that there likely is a higher viral load. So it's possible that those who are having symptoms are more likely to transmit to others. But it's very clear that, and the scientific community believes strongly, that asymptomatic transmission occurs.
So it occurs, but what you're saying is that it's a much lower occurrence than for someone who is symptomatic. Doctor?
And sorry, this time you cut out, sir. I apologize.
No problem. I said, so you're saying asymptomatic...
Can you hear me okay? It's just...
We can hear you, Doctor, yes.
We can hear you, Doctor.
I had a little trouble hearing you. I apologize. If you could just repeat the question. I'm sorry.
No problem. So you're saying that while asymptomatic transmission is possible, it occurs quite less frequently than symptomatic transmission.
No, there's clear consensus that asymptomatic transmission occurs, and it could be, for instance, that a large proportion of transmission is from a population of asymptomatic individuals. It's hard. There are some estimates. I don't have the numbers in front of me in terms of what proportions of infections would be transmitted by asymptomatic individuals in the pandemic compared to symptomatic, but it's very clear that transmission can occur from asymptomatic individuals.
Okay, is it fair to say then, at least at the current point in time, that there is no consensus, that there's still research being done and there's still learning happening with this virus?
We are still learning about this virus.
Okay. Now, I have another question regarding positive tests. If somebody was to be infected with COVID-19 and they underwent 10, 12, 13, 14-day self-isolation, can they still transmit the virus?
So that question pertains to a person's communicable period, and that period is important. And we, the scientific consensus and in the Public Health Agency of Canada, agree that a person with a mild COVID illness can transmit to others likely for up to 10 days. So transmission occurs likely about 2 or possibly 3 days before symptom onset, and up to about 10 days after symptom onset in an individual with mild illness. And again, if somebody doesn't have symptoms, we can't anchor their communicable period in symptoms. So we talk about possibility of transmission 10 days after a test in a person who doesn't have symptoms. We do know that those with more severe illness, like requiring admission to hospital, oxygen, or a critical illness requiring mechanical ventilation, can transmit for longer periods than 10 days.
Okay, so let's say a mild illness. Someone has a mild illness, they get tested, they're found to be COVID positive, they isolate for 10, 12, 13, 14 days. After that time, can they still spread the virus?
Excuse me, Mr. Adjudicator, if I could just interject here. I'm just a little concerned that the questioning is really focusing on why the reason why there might be an isolation period, or if the order is satisfactory or not in terms of what it requires. And I don't believe that that's the issue that this inquiry is intending to assess. So I'm just concerned that...
You go ahead, I'm sorry.
No, I'm just concerned the questioning is sort of veering away from the direction of providing some general information about what the order says and what it means.
I'm finding it very helpful, and I'm going to allow him to proceed.
Thank you. Sorry, doctor, again, so somebody having a mild illness, they have some symptoms, it's very mild, they get tested, they're found to be positive, they isolate for, let's say, 12, 13, or 14 days. Can they still spread the virus after that point? Symptoms have gone, they've done their isolation period.
No, so we believe the communicable period for a mild illness is 10 days after symptoms, and we don't believe that transmission occurs after that. We ask people in Northwest Territories and in multiple jurisdictions, those with COVID have to isolate for 10 days after symptom onset if they have a mild illness, for that reason, because we don't believe they are communicable to others after those 10 days.
Now, doctor, can someone still test positive after that time?
The PCR test, or the polymerase chain reaction tests, are very sensitive, and we do know that people can test positive actually for many weeks after their COVID infection. When it doesn't infer communicability, it really means that there still might be viral genetic material in a person's respiratory passage or nose or nasopharynx. But when you try to culture that virus, it doesn't culture and so we know that PCR tests can remain positive and for weeks after infection, but that doesn't infer communicability.
So basically the cells containing the virus are still there, but they haven't been replaced yet with new cells. So that could take weeks.
I'm not sure if it's just, virus, still in cells, or just, old cells with virus that, in our respiratory passages, yeah.
But just to clarify, you're saying somebody can test positive for weeks, maybe even a month after?
Yeah, sometimes even we've seen tests reported in the literature up to 3 months after resolved infection.
Okay. Thank you on that. Now, Dr. Sawyer, we're just going to get into the isolation requirements for someone entering the Northwest Territories. So when someone is entering the territories, there's a current self-isolation requirement of 14 days. Can you explain the reasoning behind that?
So the December 2020 travel restriction order had that people entering the Northwest Territories had to self-isolate for 14 days. And that 14 days is the incubation period of the virus. So the incubation period means that after a person has an exposure to the COVID virus, and if that exposure causes infection, it will take up to 14 days for a person to develop their illness. So the incubation period is the time between the start of the infection, which started after exposure. Not everyone who is exposed develops infection, but if you develop an infection after your exposure, it may take up to 14 days to develop your illness. So people may be feeling well, but because we know that transmission can occur even before symptoms start, that there is a risk that people may transmit COVID without knowing it. And that's the basis of the recommendation to self-isolate for when you traveled in from a higher incidence area at the time to the Northwest Territories.
And sorry, to your knowledge, is the isolation requirement in the Northwest Territories more stringent or less stringent than other parts of Canada?
So other jurisdictions have implemented similar travel restrictions. Nunavut, Northwest Territories, the Maritime provinces, some of the Maritime provinces had similar travel restrictions. And yeah.
Was it the same amount of time? Was it 14 days?
Yes.
Thank you, Doctor. Now, just to clarify on these 14 days, I'll give you a scenario, for example. Somebody enters the Northwest Territories on April 1st at 10 a.m. When would their isolation end?
So the application of the isolation is under the responsibility and accountability of Protect N.W.T. So our office works closely in many regards with Protect N.W.T. For instance, in our communicable disease control manual, we know it's important to count days and be as accurate as possible with our time frames, including incubation periods and communicable periods. So we gave specific guidance on how to count isolation days. So if we were going to, when we made our recommendations, it was like a stopwatch. If you entered, if you needed to isolate for 14 days, the stopwatch started, and then when the 14 days passed, then that's when we felt that it would be safe. In the application of the 14-day self-isolation, Protect N.W.T. provides specific guidance to every resident who enters Northwest Territories and gives them advice in a self-isolation plan letter, so that they will take the recommendation and they will give specific advice to everyone entering the Northwest Territories through that letter.
Okay, so just to your understanding, I'm assuming you live in the Northwest Territories?
Yes.
So if you were for you, just as somebody who is a resident, if you entered the Northwest Territories on April 1st at 10 a.m., when would you think your isolation would end?
So knowing that Protect N.W.T. advises that people isolate for 14 days and their isolation ends at the end of the 14th day. So my understanding is that I just lost my. And at the end of the day, 14 days later after I arrived, so at the end of the day on April 15th. From guidance from Protect N.W.T. But that would be communicated to each resident specifically in their letter.
To your understanding, if you arrived at 10 a.m. or 10 p.m., would that make a difference?
My understanding is that Protect N.W.T. would advise that you isolate until the end of the day after 14 days. And it wouldn't make a difference if you arrived at 8 a.m. or 10 a.m.
No, sorry, I'm saying 10 a.m. or 10 p.m.
Oh, sorry, and it wouldn't make a difference if you arrived at 10 a.m. or 10 p.m., my understanding.
One of the experts that testified earlier focused on the first day And he said that was day 0. It didn't matter what time you came in, whether it was 10 at night or 2 in the morning. That was day 0, and then you do the count after that to get the 14 days. That's the way he put it.
Yes, so 14 full 24-hour periods would be 14 days.
Thank you.
So, sorry, doctor, what kind of direction do you give Protect N.W.T, or what advice do you provide to them, or your office of the health minister?
So in the Office of the Chief Public Health Officer, there's a group of advisors that works very closely with Protect N.W.T. I am not part of that group, so there's infrequent interactions between myself and Protect N.W.T in my usual duties. There have been times, so the advisory group in our office works specifically at exemptions. When people request exemptions to the order, there will be guidance given to Protect N.W.T about that. Protect N.W.T may sometimes consult us for specific questions, and we provide them with information as necessary.
Thank you, doctor. Now, this 14-day isolation. Someone's arriving back into the province and they're self-isolating for 14 days, but exhibiting no symptoms. In this scenario, what would be the risk, let's say on day 5 or 6, of being in contact with a child? Like with their child, if they give them a hug and a kiss?
So could you clarify the question? I'm sorry.
Sure. Someone is asymptomatic. They've arrived back in the Northwest Territories and are undergoing their 14-day self-isolation. On day 5, how risky is it for that person to give their child a hug and a kiss?
So if someone returns from travel into N.W.T and then gives their child a hug or a kiss, and they were not having any symptoms, there would be some chance that, if that person came from a high incidence area, that they could have COVID, and that they could transmit COVID to their family member, to their child. The risk of importation really relates to a few things. It relates to the incidence of COVID where a person travels to. It relates to the protective measures in place at that location. So, for instance, if everybody's wearing masks, or if there's specific public health measures in place to prevent people from traveling, like asking people if they have symptoms before they get on a plane. And then it also, from Northwest Territories perspective, it depends on the volume of travelers into Northwest Territories. So we look at it at a population level, and if the Northwest Territories is receiving 1,000, 2,000, or 4,000 travelers per week, then there is risk, especially if people are coming from higher incidence areas. So again, at a population level, we know that Northwest Territories, our communities here are really resilient, but we are at risk for a severe course of COVID. Many of our communities lack the protective social determinants of health. So when we're looking at risk in terms of the policies that the order drafted by Dr. Candola and team, we're looking at it at a population level and not just specifically one individual person.
Doctor, now indulge me here for a second. If in that same scenario, the person came from a place in Canada which has protective measures in place, and they had a single dose of Moderna vaccine, does that risk get even further reduced?
Mr. Adjudicator, I think that counsel's asking the witness to comment on his client's specific situation, and I don't think that my client has information in order to do that.
Oh, but I'm finding all this testimony as the sole adjudicator very, very helpful. If he doesn't feel he's qualified, he's a very good witness and very knowledgeable. I'm sure he'll tell us, but you proceed, counsel.
Thank you, Mr. Barclay. Sorry, doctor, did you want that question repeated or?
Yes, please, yes.
A similar situation, the same scenario, but basically the person coming into the Northwest Territories is coming from one of the provinces in Canada which has protective measures in place, for example, masking. And that person also has a single dose of Moderna. Is the risk reduced further?
And I'm sorry, last I heard was a single dose of Moderna. It just broke up at the very end there.
Sorry, yeah, so they have a single dose of Moderna. Is their risk of transmitting the virus reduced?
So the initial studies for the mRNA vaccines showed that.
Sorry, doctor, I lost you after show that. Uh-oh. I think we lost Dr. Delapese.
Can you hear us, doctor? We've lost him.
Oh, no.
Pardon?
I'll have to call in again.
Can I just say something? Sorry, this is Jenna. It's a little bit difficult not being able to see the doctor. I know that that's kind of helping with his voice, just for the anticipation of when he's going to speak or when he's finished speaking. I'm really thankful to Mr. Hallaby for kind of recognizing that and pointing it out if he's not sure if he's speaking, but it's just a little difficult to anticipate when someone's going to be speaking or finish speaking when you can't see them.
I appreciate that, Jen, as Judge Barclay. On the other hand, he's a lot clearer now than he was when he first testified.
That's
You could see him just trying to balance it.
Yeah, it's kind of, yeah, we have to pick our ways in here. So, yeah, no, I get that.
Mr. Barclay, maybe a 10-minute break while Dr.
Let's have a 10-minute break and he can call back in.
Thank you.
This hearing is adjourned for 10 minutes. convened.
Sorry, Madam Court Reporter, would you be able to please read back the last part of the examination?
Sure, I just have to go back in the old file because I had to open a new one to fix the issue. So just give me 1 second.
I want to ensure that we're not repeating ourselves or.
Yeah, I'll be right back. Hello?
Hi.
And just before you go back on, because I have to switch back to the good file.
Sure.
So the last question was, a single dose of Moderna, is there risk of transmitting the virus reduced? Answer. So the initial studies for the mRNA vaccination show that, sorry, doctor, I lost you after show that.
Perfect. Thank you so much.
No problem. I'm going to go back on mute. Thanks.
Just let us know when you're in the other file so you're ready to go.
Okay. Oh boy. Did it switch language again? Oh. 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 Okay. Yeah, it's good. Thanks. Sorry. Thank you. Okay, I'm going to go on mute now. Thanks.
Doctor, are you there? Doctor?
Doctor, can you hear counsel? We've lost Dr. Pesey.
Oh dear.
I think we have to take him out of.
Would it potentially be better if maybe Dr. Pesey was given a phone number? It might be a little bit more stable.
Now, we don't have any problem with that as long as it works.
Is there a phone in?
No, for Zoom there is, but I don't know about.
This is.
What does he mean? So his conference?
If you wanted me to, excuse me, I could give him a call and ask him to use the phone-in number on the Zoom invite, if that's appropriate.
Might be a little bit more stable.
That'd be very helpful. Thank you, Tim.
Okay, I'll do that now.
See? Don't I look there?
Phone connection.
Better, way better. Just be like, yeah. It's when you start adding video, it's so much more complicated. It's just good.
He's just going to call in now.
can you say something, please? We can't hear you.
Can you hear me okay?
Now I can hear you, yes.
Yeah.
Doctor, are you able to hear me?
Yes, I can hear you.
And so are we back on the record?
Yes,
I'm
I
just on the
had,
Proceed.
telephone.
Thank you. Doctor, sorry, before we took the breaks, you were describing what a single dose of Moderna or an mRNA vaccine can do.
Yes, so the original trials for the mRNA vaccines demonstrated that after 14 days after a single dose, there was a reduction in the risk of acquiring infection, so that dose of vaccine prevented probably 90 to 95% of infections. In the trials, a second dose was given, that kind of 21 to 28 days after, so it was uncertain the duration of that protection from one dose. But one dose, 14 days after the dose, starts to show effectiveness in preventing COVID infections.
What about transmission?
There was uncertainty, and the observational epidemiologic studies that we looked at in early 2021, in the first few months, started to demonstrate that everyone's best assessment was that it would reduce even asymptomatic infections, and that being said, also likely reduces the risk of transmission after you received 2 doses of vaccine. So that's for 2 doses, not 1 dose. So I'm sorry. So 1 dose, I don't have any evidence on reduction of transmission, but 2 doses, the data from early 2021, from the first few months, started to demonstrate evidence of reduction in asymptomatic infections, and the scientific community started believing that there was a reduction in transmission from 2 doses.
Okay, so sorry, just to confirm, you can't answer if a reduction in transmission occurs from 1 dose because you don't have the knowledge from the research yet. You haven't received that, correct?
Correct.
Thank you, doctor. Now, what about masks? How do masks reduce transmission, and how effective are they?
So masks reduce transmission, we believe, because they are source control. They, when a person's wearing a mask, the respiratory droplets, which may contain infectious virus, are collected on the mask and not distributed to the environment or to within 2 meters. We believe that as source control, that they can prevent infections, especially when used by populations. When everyone's wearing a mask, we believe that reduces the burden of virus in the environment and people's exposures and can reduce transmission. In terms of the data on the effectiveness, it's very hard to get that data because along with masking guidance, there's many other public health measures in place, and so I haven't seen epidemiologic data that answers that question yet. But the hypothesis is that it can reduce transmission of COVID-19, especially when used by populations.
Okay. Now, doctor, have you ever been to the Great Hall, the Legislative Assembly?
I have, yes.
It's quite a large, high-ceiling, open area. Is that a correct? Is that a fair statement?
Correct.
Okay. Now, if that space was only populated by 2 people, both wearing a mask, would you say the risk of transmission is low, especially if they were kept at a distance?
In a large room, if 2 people were both wearing masks and at a great distance apart, the transmission in that situation would be deemed low. Especially, we'd have to consider the exposure time as well. But in a large room with 2 people wearing masks and distance apart, especially for less than 10 minutes, we would actually deem that to be a low-risk situation for transmission of COVID.
Thank you, doctor. Now, What about a situation outdoors? Let's say if somebody was to go up to somebody's walkway and speak to them at the door, you know, where they're kept over 2 meters apart, outside and wearing masks, would that also be a low risk situation?
Yes, outdoors, the ventilation is unlimited, and so it is. If two people are outdoors and at a distance, and both wearing masks, and one person has COVID, the risk of transmission in that situation is low.
Okay. Now, Dr. Sir, I'm just going to go back to the 14-day self-isolation for people entering the Northwest Territories. The risk of, let's say they did contract COVID out of territory and they returned and are doing their 14-day isolation. Is it fair to say that they are less of a risk near the last final days of their isolation?
So from the data which estimates viral load through the course of an infection, the estimate is that people are most infectious early on in their illness, and sometimes even before they develop symptoms possibly, and that infectiousness decreases as a person progresses through a mild illness. So viral load appears highest early in a mild infection.
So near the, let's say the 12, 13, or 14-day mark, the risks are reduced, albeit possibly still there, but reduced. Is that fair?
That's if somebody returns with a COVID infection, but the incubation period means that a person can develop the beginning of infection within a 14-day period. So somebody could be exposed when they're traveling, return to Northwest Territories, and 12, 13, or 14 days later, we believe, start their illness. So they would be very infectious at that time.
Oh, so the 14-day self-isolation might need to be a month then.
Well, 14-day incubation period. The World Health Organization uses 14 days as an estimate of the maximum incubation period. So if a person, waits 14 days after potential exposure, and they don't have symptoms, and in some situations, we recommend testing those who were exposed, like some household contacts who have very intense exposure, or a contact who has an exposure to a close contact. We would advise in Northwest Territories that they have a test as they're exiting their incubation isolation period, their 14-day isolation period. So the test would be reassuring, and then they would not need to isolate further.
Doctor, have you, do you know if anybody from your office or part of Protect N.W.T, have they made this type of recommendation to have a test done near the end of the isolation?
So we have asked in some situations, Dr. Candola, the team, has produced guidance to recommend testing asymptomatic individuals. And early on in the pandemic, that was essential workers who, by the nature of their work, couldn't isolate and needed to work. So we would have testing as they entered Northwest Territories and while they were asymptomatic. But we didn't have recommendations that every individual who entered, any resident who came back from travel, have a test at the end of their incubation period. That wasn't in place.
Sorry, Mr. Barclay, if I could just have 2 minutes?
Would you like a little longer?
Sure, 5 minutes is fine.
That'll be fine.
This hearing is adjourned for 5 minutes. Hearing is
Doctor, are you
resumed.
still with us?
Sorry. This hearing is resumed following an adjournment.
Doctor, are you still there?
Yes, I'm still here.
Oh, wonderful. So, Doctor, just a few more questions. I want to move from the medical and scientific side of COVID-19 over to the public side. And are you aware of any confusion from the public regarding isolation protocols, anything to that nature?
So we have given the public lots of information. We've been giving the public lots of advice, and some of the advice is quite complicated, and there's a lot of information to review. So I believe that there can be confusion with some of our guidance in our advice.
Thank you, Doctor. Regarding, for example, the self-isolation plans, I don't know if you're aware. Are you aware, for someone that's self-isolating, how they receive calls throughout their isolation?
Yes, Protect N.W.T. or Statistics Canada will call to do symptom checks as people are self-isolating, or they submit symptom checks online.
And were you aware that on or before the last day of their isolation, they also receive an email stating that this is their last day of isolation?
I wasn't specifically aware.
No? Okay, thank you. Do you know what efforts... Sorry, do you know what efforts might have been in place in the beginning of this year, or the beginning half of this year, for ensuring that the public understood what was required to protect themselves?
And like to ensure that the public understood how to protect themselves in general, or I'm sorry,
from COVID-19 infection. Well, what has changed since the beginning half of this year? How has the N.W.T. strategy changed?
How has the evidence changed in terms of COVID protections?
No, how has the strategy changed in terms of informing the public on how to protect themselves from COVID-19? I mean, obviously, we're seeing a bit of a resurgence now. Has the GNWT done anything differently, in your opinion, to ensure that the public are taking precautions?
So the GNWT has, I believe, continuously communicated to the public on measures. We issue regular public health advisories. In those public health advisories, we provide a situational report to the public. We advise of, community transmission. We advise of exposures to public exposures. So the communications team in the Department of Health and Social Services that work with Protect N.W.T. and work with the Office of the Chief Public Health Officer are really producing a lot of communications. I know that we will also use in our small communities radio-based communications. In some situations, it really involves door-to-door campaigns to ask people, to inform people about vaccine clinics and opportunities for vaccination. So there really has been a wide array of communication strategy to try to help empower the public to protect themselves.
Sorry, this may be a little off topic. Please, if I may ask this one other question: when they are communicating with the public, are all the official languages of the Northwest Territories being utilized to ensure that the message is getting across?
And I think, so I'm not completely aware of our utilization of all 11 Indigenous languages. I know there have been great efforts to do so, but I haven't seen all the completed products or communications.
sorry, Doctor, if I can just go back to the 14-day quarantine. Are you aware that people are often unsure of when their quarantine is done, when they can leave self-isolation?
I'm not aware how often that occurs. I am aware of the possibility, but I'm not aware of how often that might occur.
Yeah, so, you know what, thank you so much, Doctor. You were very informative. Those are all my questions.
Thank you very much, Mr. Hullaby.
I have no questions, Mr. Barclay.
Dr. Pise, it's Judge Barclay speaking. On behalf of all of us that are participating, I just wanted to sincerely thank you for your testimony. You're very knowledgeable and articulate, and we're all a little wiser after listening to you. So Godspeed, and thank you for your help.
Thank you for the invitation. I know.
The evidentiary portion of the hearing is now over, and I'm going to adjourn this matter until Tuesday, November the 2nd at 9:30 a.m. for submissions. Thank you again. And
sir, I just have one preliminary matter that I want to simply put the inquiry on notice that we will be bringing a motion that will be required to be heard before our final submissions. It concerns what we understand to be what we say is a serious breach of the privacy and confidentiality, which is mandated by both the Legislative Assembly and Executive Council Act in conjunction with the Public Inquiries Act and your own rules established for this inquiry. We are just in possession of information now, and we will be using some of the intervening time to put together the appropriate material for the motion. And although we don't anticipate requiring any more than the time set aside already for closing arguments, and we do anticipate that we may be able to accomplish two things at the same time on November 2nd, I wanted to alert you, sir, and Mr. LaPrairie, that we do intend to bring a motion with respect to the consequences of what we say is a serious breach of confidentiality and privacy according to the Act and your rules.
Mr. Cooper, is that arising? There was a newspaper article that was brought to my attention in respect to an allegation that an MLA wants to know how confidential documents made its way to the clerk's office. Is that the issue that you're going to bring this motion on?
I'm not sure which media report to which you're referring. I am aware of and have been queried about some of the information that is now part of the public record and the media. I will say that the media has only a portion of the story, which is probably proper given the material and its inherent confidentiality. No, it has nothing to do specifically with the clerk's office. They may be peripherally involved. I'm not in a position at this point, sir, to give you the full nature of the application or the evidence, but
my understanding is that this arises out of the application that you made in respect to the issuance of subpoenas, and in support of your application, affidavits were filed, including an affidavit by an MLA. And my understanding is the complaint is that that particular affidavit was brought to the attention of a committee in the legislature. When you're considering your application, you must consider, one, in respect to confidentiality. I've already made a ruling that the confidentiality doesn't apply. And more importantly, this arises out of an application before the court, and everybody that walks into that courtroom would have access to these documents, in particular the affidavit. And if you're making this motion arising out of the affidavit that was filed, it's clearly a matter for the public, and there's no confidentiality at all. And I'd ask you kindly, as an officer of the court, Mr. Cooper, to revisit it. If you want to go ahead, we will deal with it on Tuesday. But if that's the basis for your application, there's no substance to it at all.
Sir, it's disturbing, frankly, to have comments coming from the sole adjudicator presupposing certain matters based on a media report, the nature of which I'm unaware. It is.
Well, you're quoted in the report.
I understand that, sir, but I don't know which report to which you're referring, and I don't litigate through the media. In this instance, sir, we're asking you to keep your mind open and allow us to make the application before prejudging the application, sir.
No, I have no problem with that, and you'll get a fair hearing. That's been my practice for about 50 years. But I just wanted to warn you, if that is the basis for your application, I just ask you kindly to consider it as an officer of this court. But you'll have a full hearing before me, and we'll listen to all your submissions.
Thank you, sir.
The matter is adjourned until Tuesday at 9:30.
This hearing is adjourned until November 2nd at 9:30 for submissions.